This is October 5th, 2021, live from Mexico, Hospital Angeles, Interlomas, with the residents from the critical care program here, Sylvia, Rodrigo, and their Professor Eric. So let's get started with some of the cases. So the first thing is the disclosure is we don't have any particular mode of mechanical ventilation, no endorsement of any particular mode, manufacturer or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic or the Hospital Angeles of Interlomas. I'm Eduardo Mireles, and Rob Chatburn is also on the line. Here are our disclosures. The ground rules, this is a recorded session, so keep your microphone muted. The moderator may call upon members of the audience to comment. If you want to comment, just use the chat function. Today, because we're traveling, we're not going to use the poll function, and we have several cases to see today. So here we go. So I'm going to ask to any of the team in Cleveland if anybody is interested in trying this waveform. Anybody?
I can go to Mireles, UD here.
Udi, okay, thank you very much. So Udi is one of our first-year residents fellows in critical care, in pulmonary critical care. You're a second year, right, Udi?
Yes, sir.
Second year pulmonary critical care fellow. So go ahead, Udi, talk to us. You have not been demoted, Udi. Go at it. What's the tag for this ventilator setting? And it's actually in Spanish because these are waveforms that the program over here gave us. So go at it.
So I would say that the tag here is, first of all, the control variable is pressure control, because the flow waveform is not really machine, it looks different. I would say it is IMV type 1 SS.
Okay.
If you want, I can go into why we're saying this.
Just read the whole waveform, and then we'll ask you why you came to those thoughts, and see if there's questions or other issues.
Sure. The load, I would say, is both inspiratory and expiratory is elastic.
Okay.
The trigger, as the waveform, as the screen what we're seeing, I think there is early trigger in the second breath.
In this one?
Yes.
Okay.
Inspiration, I would say that there is work shifting on the fourth breath, that is the breath most to the right of the screen.
Okay. Second. Go ahead.
So cycle, and I had some, I think, some trouble with this cycle. I would say early cycle, and again in the fourth breath, but I may be wrong.
Okay.
And in expiration, I would say it's normal.
Okay. All righty. So let me see if there's Rob. Is there any comments on the chat?
Not yet.
Not yet. Excellent. So let's start by the tag, which I think that's non-controversial at this time. Let's start with that. So PC. So I think that you're right. So you can only control either pressure or volume on a ventilator. So we definitely agree that you're controlling pressure. The flow waveform is different on each one of them. So that's a given. IMB. This is good because this ventilator keeps the past shaded, so you can see what the patient had done before. If you had only seen these two breaths over here, you would not, this could be just pressure support or any spontaneous mode by itself. But because you see this one over here, in which the breath ended and then there's another interaction here, it's longer and the pressure is higher, this is certainly looks like a mandatory breath. So I agree with you on that, Udi. It looks like there's spontaneous and mandatory breath. So if both of them exist, that's a intermittent mandatory ventilation. And then you talked about the type 1, and so I'm gonna ask you or anybody on the line if they know the different types of IMV that exist. Um, Anybody wants to jump in?
So there are four types of IMV. Type 1, which I chose here, is when the mandatory breaths are delivered at a set rate, uh, and the spontaneous breaths can happen anytime. The way I like to think about it is like a complete heart block. Like, the spontaneous and mandatory are marching to their own tunes.
Yes. Mandatory occur regardless of spontaneous, right?
Yes.
Excellent.
Type 2 is when mandatory breaths are only delivered when spontaneous breaths are below a certain rate. So basically, it's like a backup rate. When the rate falls down, then the machine kicks in.
Yes, so so spontaneous suppress mandatory.
Right.
Okay.
Type
All
3
right.
is Yeah, type 3 is when the minute ventilation falls below a preset value. So the minute ventilation target suppresses mandatory. If the patient is able to both have a rate and a volume to set a target minute ventilation, then it will suppress the mandatory.
Perfect. When the target is met with spontaneous, it suppresses the mandatory.
Yeah.
Very good. And
And
4?
then type 4 is when basically it depended on patient effort, which is kind of tricky. When the patient effort is a lot, then the mandatory changes to a spontaneous breath. So depending on how much a patient is having an effort, that is, if the patient is continuing to have an effort even after the P vent is supposed to stop, it changes to spontaneous. So kind
Yeah.
of dual targeting.
So yeah, so this actually happens only on dual targeting in some versions of dual targeting. So the one that the servo U and the servo I has is when the patient's breath is longer. It triggers the breath and it's longer than the set I time. It goes too long and it becomes a spontaneous breath instead of mandatory. So that's it. Rob, any comments?
No, that's a very good explanation.
Excellent, Uri. So I think I completely agree with you. And actually, you can barely see it here in the picture, but if you go and see on the Rosetta Stone that we have for all the modes, you'll see the PB. This is a Puritan Bennett 940, 960, 980. Sorry for demoting you. It's 980. Um, this would fall under exactly these classifications, which is set point, and set point meaning you have to set the amount of inspiratory pressure that the patient would get on the mandatory and on the spontaneous breaths, which you can see on right here on the bottom. Any disagreements? We agree? Alrighty. Okay. Excellent. So then what is the elastic load? The elastic load, so what is the load? You said it was elastic, and I presume you said that because it returns back to baseline very fast, with less than a second from it, which would I would agree that this is elastic without a doubt, and you have both on the inspiratory and expiratory phase. And this is a classic example of somebody that has enough to trigger, but then it essentially becomes, it just triggers the breath, and then there's no more PMOS throughout the breath, or not significant PMOS. So this looks like elastic. Rob, disagreements?
Nope, that's good. Does this ventilator doesn't seem to indicate with a different color if the patient triggered versus the ventilator triggered? Or
Right.
is that the difference between green and red?
Right. So this ventilator, and actually I have the experts here because they use this ventilator all the time, changes the color for spontaneous breaths and for mandatory. But to indicate if it's a spontaneous or a mandatory, it does it by this in this upper corner, puts an E if it's spontaneous, well, S in English, or it puts a C if it's mandatory. So we would not be able to see that from looking at the waveforms, the indicators. All righty. So let's take a look at the PV discordance, at the patient ventilator discordance. So the first one is trigger. So let's take a look at this, Udi, because you said that you thought that the second breath had a early trigger. So who triggered the first breath?
The machine.
So this one over here is a machine.
Yeah, I think so.
So this is a spontaneous breath over here.
Yeah, that's what I thought.
It's the other way around.
Oh,
So actually, just by looking at the pressures that you require for each one, so the coloring of the breath, this is a mandatory breath according to this ventilator. Yes. And this is a spontaneous breath. So if this is a spontaneous breath, who triggered the breath, Udi?
the patient.
Excellent. Who cycled it?
I think it's the patient.
Excellent, because it's a spontaneous breath.
Mhm.
So who triggered this one? The patient, right?
Patient. Yeah, this one's
Who
patient.
cycled it?
Patient.
The patient. Patient, patient. What about this one?
Machine.
Machine. Who cycled it? The machine, right?
Okay.
Now you see that?
Yeah.
So now that you know this, this is good. Now that you know this, what do you think now about this little sucker here? Because I know that that's what triggered you to think that that was an early trigger.
Then that should, I think, probably be expiratory. I mean, could be an effective trigger, but I think it's quite early. Could be expiratory work shifting. I mean, is this blowing out?
So, so usually when you see it so early at the beginning of the next breath, it's either early cycle or a early trigger of sorts. But because this breath, in our definition, we said that this is a trigger by the patient, and it has to be a mandatory breath to be an early trigger. This looks like early cycle of sorts. I would expect the pulmonary the PMOS to have gone away already by that time, but you can actually see how the I mean just the same thing that we saw here. There's evidence of effort, and you see the exact same thing over here. The patient took effort after the breath had ended. He had another episode of effort. So
Early cycle.
I really struggled with this one for a while. I was thinking, well, is this patient having two breaths, one after the other? Is he having early cycle? I wanted to hear the thoughts of the group. Rob, what are your thoughts?
Well, if you look at the peak expiratory flow of the first two breaths, they look like they're the same.
Yes.
Maybe the second one's even higher. So I don't think the effort is bleeding in to the cycle phase. I think the patient is somehow reacting to his lungs exhaling and trying to inhale rapidly again.
So kind of an early trigger kind of behavior.
Yeah.
I see that here too. Anybody else?
It looks like it's a behavior that he's doing every time. And with the mandatory breath at the end, you can see that the eye time is sufficient. So if it was a matter of continued PMUS when the machine, when the like spontaneous breath cycled, then he should have had continuous flow. But he drops his inspiratory flow down to almost zero, and then he starts again. So for some reason, he's doing this pattern where he breathes in, I think, and then he starts to breathe in again. It just happened during expiration with a spontaneous breath.
Yeah.
I really like the point that was pointed about the peak expiratory flow. That's a nice way to kind of figure if you still had PMS at that point or not.
Right. So if you were expecting the patient to have PMOS, you would have expected the peak expiratory flow to be lower, right, than what it's over here. So I think that I'm moving towards it's either failed trigger or an early trigger of sorts. And this has been described, that type of phenotype, which happens on early expiration. But this violates the rule that we said that it's usually a mandatory followed by a patient effort. So unless somebody goes against it, I would say that this looks like early trigger or a double effort, one after the other. This would be a good one to put a pause, an expiratory pause, and see what the patient does, or if it does anything.
I wouldn't call it early trigger. Like, I think failed trigger, yes, but early trigger, I mean, there isn't a machine trigger to say that it came earlier than the patient. This is the patient himself triggering. So I cannot feel comfortable calling it early trigger. If anything,
You're
maybe,
gonna go for failed.
yeah, failed.
I would agree with that too, but here's another thought. I'm just throwing this out here. The so-called reverse trigger or early trigger happens because the patient is somehow have this reflex against an inspiration caused by the ventilator, right? Well, what if the patient has a similar reflex where he gets triggered to inspire from an expiratory flow? So he senses his lungs are collapsing and tries to make an inspiratory effort. And maybe I don't know if that's been described before, but that seems like it would be a reasonable kind of reflex that somebody might have.
I like it. I'm gonna put it here. This is we're gonna call it a failed trigger, but there's this expiratory reflex, and actually this is not the first time I've seen it. I just don't know how to explain it.
Yeah, I've seen it before too. I don't think it's been
Yeah.
described in the literature though, has it?
Right. We'll call it the Angeles effect. All right. Very good. In terms of inspiration and work shifting, I think that there's very little, if anything, Uri, that I would probably say that this is absolutely normal, unless somebody disagrees with that. Why did you think there was, or did you think that was a tiny bit of work shifting? What was your thought there, Udi?
So I mean, if you see the mandatory breath on the fourth breath, and then you see the little where you put in the arrow, I mean, I thought there was some.
A little bit of, yeah, I mean, there's minimal work
Yeah.
shifting but you don't see any change on the pressure, minimal change in the pressure. So there's some activity, but I would not put it as a primordial thing. Does that make sense?
Yeah.
Alrighty. And the cycle, we talk about it. So this is actually in this one, it's probably late, if anything, on the only one that exists there, right?
Yeah.
Okay, late. And then final expiration, it looks perfectly normal. Alrighty. So now comes the interesting part. Would you change anything? Or you would leave it in peace?
Why? I mean, what is? I think first of all, where are we at with the ventilatory management? Are we with comfort, safety, or liberation?
Right? Comfort, safety, or liberation. Do you want the patient to be comfortable? All right, it's comfort. So it's either synchrony and balanced work of breathing.
Okay.
Would you change anything or leave it in peace and you're like, okay, just a little bit, nothing major?
I mean, it's hard to say, but I guess why is the patient kind of double? I mean, not double triggering, but having this pattern of to
We don't know.
So I would like to look into the causes of this. I mean, certainly I would try to reduce any kind of desynchrony to a certain extent. And if this is happening at a consistent basis, I mean, does the patient have some neurological problems? Or the other?
This is a difficult one to eliminate, right? Because they already have the sensitivity at 5%, so it's as low as it can get. So this is going to be hard to eliminate with the ventilator. I mean, this one is easy to eliminate, but this one is going to be hard.
So
I don't know.
why not do only pressure support? I mean, the patient's triggering.
That's a good question. That's absolutely a question. So you would say, well, let's do PC, CSB, S as the single one without having the mandatory breaths there.
Yeah,
right?
the chat, Eduardo says we've got comments from Karsten Roberts and Morgan Sorg. They're both questioning the long eye time on the mandatory breath. But I think the further analysis is, why do you need the mandatory breath in the first place if your goal is comfort?
Right. So if the goal is comfort, that's the benefit of putting this into context, is saying, well, you know, I want comfort. Maybe there's some desire to have some safety and keep the patient with a given minute ventilation, and that's why those extra breaths are there. So that those are strategies that you may try to attempt to do to
That could
keep
be because this ventilator doesn't have anything but type 1 IMV, unfortunately.
That's correct. So there's no other level of sophistication in the IMV of this.
Right.
All righty. Well, we learned a fair amount on this one. We talked about SIMB, the elastic load. We described the this reflex or pattern that we have seen that it doesn't fit an early trigger. It looks like a fail, but it's really not entirely clear, and probably an end expiratory pause would help us to see the reality of what the diaphragm is doing, or if it's doing anything. Maybe it's truly a reflex. And then we talked a little bit about the goal, and if pressure support would be a goal. Any comments, disagreements? All righty. Thank you, Udi. Excellent as always.
Can I still be in second year?
Yes, Udi. Actually, you're a SEVA master, so you can stay at second year. Thank you. All right, let's do another one. Woo! All righty, who's gonna do the next one? And I'm gonna give you a chance. You can choose between this one or that one.
I can take it,
Anybody?
Dr. Morales. This is Samir here.
Samir, which one do you want?
Well, both of them look interesting. I can
Excellent. So let's do this one.
yeah, let's do it.
All righty, let's do this one. Are you ready?
I am.
Okay, so take us through it.
So the tag, the control variable is pressure, based on the square-ish waveform I see. Again, based on the conversation you have with Judy, it seems like the breaths are patient triggered and patient cycled, at least, or part of it is. So CSV, and I think it's all set point. So I will say S is the targeting scheme. From a load standpoint, kind of hard to make relevance, but if I have to put anything, I think the inspiratory load seems to be elastic, and that primarily is that, you know, the peak, there's no like high peak of during the inspiration, there's no like high peaks required to overcome resistance in the flow waveform before it starts ramping down, and the time constant is one time constant required to reach baseline and expiration. So I would say mostly seems like elastic load. Don't see any PMUS over here to say that that's the contributing factor. There is some these oscillations that could be cardiac oscillations or just secretions in the expiratory limb. The PV discordance, I mean, it's a patient trigger, patient triggered breath. So I think all of the trigger is normal. At least I don't see any discordance in terms of triggering the vent. Inspiration wise, again, no dipping of the flow waveform. So I would say normal. Cycling, I think it's flow cycle based on 25% decline. I don't see any signs of late or early cycling. And in the expiration, other than those secretions or oscillations, I don't think there is any PMUS or effort that would you know, impair expiration. So I would say expiration is normal as well.
There's a question over here. Go ahead. Yes. So the question is what about the tag? So I'll just so PC means that it's pressure control, so that we're controlling the pressure. Then CSV stands for continuous spontaneous ventilation. So all breaths are spontaneous. So they are triggered and cycled by the patient. And then S stands for its set point, which set point, which means that it's the targeting scheme, which essentially means that you set all the variables. So in this case, it's you set the pressure at which each breath is going to go up. So that's what this means. Let's talk a little bit about the load, Samir, because I am a little bit. Let's talk about what you see. So you see the flow goes up,
Yeah.
and then it takes a while to reach the cycling point. Then it the exhalation starts, and there's all these irregularities. And you probably can argue with me that the scale is the gain on the flow is hard to see. It's very small.
I can barely see the number. Yeah, I
Yeah,
think is it on the scale of 20s? Am I correct?
Right.
yeah.
That changes a lot.
Okay.
Yeah, I thought there were scales of 5. Oh, hold on. Yeah, this is
So,
better.
so what are you seeing here?
Yeah, I think there's a lot of like initially the if it's 40 centimeters of water required to start
No, this is
flow.
flow. This is flow,
Oh,
Samit. So
sorry, I'm on the wrong part of the screen. Sorry. Yeah. So the peak inspiratory flow is somewhere between 40 or 50, I believe. Like I think mostly close to 40, if I'm not wrong.
so let's go in part for here. I don't think that the flow itself, it doesn't really matter. It's just that you're seeing it very small.
Mm-hmm.
So that sabotages you sometimes, and it's hard to see the reality because the scales are small. But what I would point out here is the time that it takes for this patient to get from in the beginning of exhalation to the end. And sometimes when I cannot see on the flow waveform, I look at the volume waveform, and you can see that the scale is much better than up here.
Mm-hmm.
And it takes this patient, so if it starts right here, it takes the patient all the way over here to exhale, to actually a little bit
Yeah.
even more. Does that change your behavior, your thoughts?
Yeah. Yeah, absolutely. I think not reading the volume waveform makes it more like a miss for me. And I think now looking at the scale and now looking at the time, it makes sense that this is a very long time constant.
Mhm.
So I would think this is a resistive load.
Yeah, I think that's what looks to me. I mean, there may be some effort there. The other thing is when you see the inspiration, it doesn't look. I mean, it's not going like that or even close to that. It looks actually like it has a. So there may be some effort on this patient. So it's hard for me to see it very well. Uh, I don't know, Rob, if you agree with this or disagree.
Definitely, I think it's hard to tell because of the scales. I would suggest that because this is pressure support and because it seems to be a little bit concave downward, that there's probably some inspiratory effort in there, slight. As far as the being a long time constant, a normal time constant is on the order of about a 0.5, 0.6 seconds. So that's like, to exhale 95% is like a second and a half, which is what we're seeing here. So I'm not sure that I'm seeing a long time constant. If you
Well, it's
divide that
taking
by
around 2
3, right?
seconds if you see where it's finishing. It goes from a little bit less than 2 to all the way to more than 4.
Okay, so if the normal time constant is half a second, then that's a second and a half to 3 seconds. Second and a half to 2 seconds is only 3 time constants, right? So
Keep on going.
I'm just thinking. I mean, a if a normal time resistance is about 10 for an intubated patient, and a normal compliance is, let's say, 60, then that's 0.6 seconds, and you multiply by 3, that's 1.8 seconds
Yeah.
for 95% exhalation. So that seems within a range of a normal resistance and compliance.
Fair enough. It all depends on what's the physiology of the patient prior
Right.
to this, right?
Right. You can't tell really.
Right. So it would be probably normal to either increased or but not, it's not short. We agree
No,
with that.
no. I'm not saying
Alrighty.
that.
Alrighty. So it's either normal or increased resistance.
Yep.
Thank you. That's very useful, Rob. Appreciate it. And then PV discordance, I think that you read it perfectly right. It's a very nice normal waveform. Would you change anything with this?
Depends on
Such
where the patient is in terms of their, I mean, this is a freshly intubated patient with the goal of safety and ensuring minute ventilation. I think we have to see the volume and the type and the height to see if it's within the 6 to 8 safety limits and whatnot. So it all depends where the patient is in their. I mean, if the goal is about liberation, I think we are probably close.
Yep. Questions? No. So yeah, I think that we're aligned on that. And so this patient is essentially ready to be freed from the ventilator, could potentially breathe on their own.
Yeah.
Right.
Yeah, and I think that was a great learning point for me to focus on the scales as well as the whole waveform.
Yeah.
That just gives you the data, and then the comparing the time constants both on the volume and the flow scale would have been interesting. I think that would have been. I don't know if yeah, I don't know what the oscillations are. Could be
I think
secretions or
those are
could be
secretions. The
secretions, yeah. Guy needs to be suctioned.
suctionation in the nation. Alrighty.
Alrighty.
Right. Great job, Samid. Very
Thank
good.
you. Thank you,
We're
Dr.
warming
Moran.
up.
Yeah.
Or water in the circuit. Thank you, Morgan. I was able to catch that. Any comments on the chat, Rob?
That was the last thing. Well, we do have one that says on pressurized a lot, 60% here. We have often you discuss it how we don't know why this ramp built in. Do they use the ramp on the pressurized a lot? You
Can
guys.
you? I don't understand.
So sorry, this is UD, Dr. Mireles. I just wondering that how the pressure, it seems like there is a ramp on the pressure, right? Say 60%. We have often talked how
Oh,
we don't know why it's here and we have to change it because it kind of makes the waveform look funky. Do they use it a lot there? And because we don't seem to find why it's here, right? Why the pressurized has a certain ramp to it and not doesn't go straight to the initial pressure. Just curious.
you're talking about the pressure rise time, correct, Dudy?
Yeah.
Yeah. That's we talk a fair amount of this. In general, we try to use it as short as possible, so that to minimize any work of breathing and pressurize the system as fast as you can. And it should have no adverse or ill effects. In some patients, it can early cycle, but in majority, it doesn't. I don't know, Rob. Any other comments on that?
I think people use it for very ambiguous reasons. Some people say that you could use the pressurized time to adjust the patient's comfort, but I really don't know how to do that. I'm not sure that that's a valid way to think about things. Not sure.
So essentially, just for everybody, that rise time, I'm amplifying the waveform here. It's just the time, instead of starting if this was at 100%, this would rise immediately up. Because it's at 60, it rises with a little bit of a delay. If you drop it even further, it would drop even lower. So taking more time to reach massive pressure. But
we use it in weak patients. Basically,
yeah, the comment here is in awake patients, they adjusted according to comfort, which and actually I've seen there's a respiratory care publication actually talking precisely about that, about the rise time and comfort overall. So that would be a good project to try to figure out how to actually grade the comfort and adjust that. All righty. Very good. Cool. Let's do another one. Who's gonna jump to the next one?
Or
Anybody?
somebody else is here.
Who's that? Who's gonna do it?
I can go for it.
Okay, Ahmed. Do you want this one or this one?
Well,
Or this one?
well, let's leave the path on its own, and let's start with the first one.
Okay. Let's do this one then. All right.
So
Go for it, Ahmed.
glad to
So
see a
what's the
familiar
tag?
screen. The tag is looks like it's a PC. I'm gonna say CMVS, and
Okay.
the load is PMUS and inspiration. And looking at the expiration, it's looking more of an elastic. And then PV discordance, evidence of early trigger. And cycling, you could maybe say that there's a tiny bit of a late cycling in the first breath. You can see a small pause on the flow, and you can see that it's peaking at the end. And then inspiration-wise, there is some work shifting, but it's very mild. And expiration is passive. There is no significant work.
All righty. Very good. Anything else, Ahmed? Good job. So let's read it. Any comments from this side? You agree with his read? More or less? All right, so let's go at it. So the tag is pressure control. CMB, continuous mandatory ventilation, and it's set point, meaning you can see here everything has been set. Even though it's in Spanish, this is pressure above PEEP. This is the respiratory rate, the PEEP. So everything has been set by the clinician. The elastic load, is PMOS, as you pointed out. Instead of coming down nicely, all of this is PMOS. And then elastic, it returns rapidly back to baseline from expiration. So I think that you're right on that. And then the trigger, this ventilator actually does change color when it's a patient triggered, and this looks like all mandatory breaths. And after the mandatory breath, there's evidence of effort from the patient, which I agree with you. That's called early trigger, which in the literature in general right now, it's called reverse. Excellent. And then inspiration, there's some work shifting, as you pointed out. So because the patient is doing effort here, the pressure drops. The cycle looks actually late, which is usually atypical in these cases, but you can see a little hump, a little pause, as you pointed out, Ahmed. But in this case, it's with the presence of this PMOS, I would probably not be able to comment. I would say there's the early trigger is the one that's causing all of this. And then the expiration is totally normal. So I agree with that. Comments, Rob?
Yeah, I just want to say one thing about, you mentioned that this is called reverse trigger in the literature. And I think that people should make the distinction between the name of something and the classification of something. So
Yes.
it's classified as early trigger, but they call it as a name, like a shorthand name as reverse trigger. It's the same way we can talk about a mode of ventilation called pressure support versus pressure control CSV, right?
Right. Very good point. So this
Hey,
is.
Sorry,
Go ahead. No, go ahead, Ahmed.
So a quick comment here about maybe my understanding of this. So with reverse triggering, I think about it this way. It could happen because of two things in my brain. Either you're entraining the rate of the patient, or it's a reflex secondary to the mechanical breath that you're giving. Somehow it stretches the lung, the diaphragm, and the patient triggers. So that's how I'm thinking about it. And that's why I would say, yeah, it's early trigger, but it could be an actual true reverse triggering, or it could be you're just entraining the patient. And the only way I figure this out is by dropping the rate and see what the patient does.
Yeah, I think that that's actually a good point, and I try to make this distinction in my brain very often. That's why I don't use the name reverse trigger. In my mind, there's many causes for early trigger. There's many in which you would see this pattern in which the ventilator triggers first and then the patient. Some of them is entrainment, as you said, of the respiratory rate. Others are the that reflex that occurs, that was the beginning, what we thought. There may be other causes, like a simple hiccup or a simple reaction of the patient to something else, and that you will see it here. But if I call it reverse trigger, I'm putting one mechanism behind it, and then I cannot mention all the other potential causes that could go for this pattern to see. I also think that as we learn more about reverse trigger, we're going to have to come to terms and decide if reverse trigger is the right name, or we're going to fall into reverse trigger is actually the reflex one that you just call describing, which we drop the rate and nothing happens. Or we're going to call it entrainment, and entrainment is going to be another cause, because the treatment for both are different. So I think that that's the reason to use this classification, and to then from there say, well, and the cause for this is this, this is what is actually triggering or causing this pattern, rather than putting a name that has a cause for it. I don't know if that makes sense, or if there's disagreement with the audience. I would be interested to hear.
Dr. Mireles, I think of this in a different framework, a different paradigm. I think sometimes it's helpful to put all PV discordance. I think of it in basically two things: that what is the P vent in relation to PMUS? Like, how much of ventilatory support is the patient getting? And depending on safety, comfort, and liberation, is it that are we trying to match P vent, or is the ventilator giving too much support to the patient, too much ventilator support, or too little? And then say, okay, if the ventilator, basically in early trigger, the ventilator is faster than the patient. That's what it is. I mean, whatever the ventilator is doing, the patient is reacting to that. So is the ventilator giving too much support or too little support? If it is if it's in safety situation, you want the patient to do nothing. You sedate the patient, do everything possible to ventilator takes over. In comfort, you try to match the two pressures, and in liberation, you try to back off the ventilator so that the patient takes over. This is sort of paradigm I find it more useful, because it's like a more global assessment. Wondering if that makes sense.
Well, I think that you're talking about different things, Udi. One thing is the classification. The other is how you deal with it according to your goal. And that's what I think you're talking about, is how do you deal, how do you put them in reference to your goal of mechanical ventilation? Is that correct?
Yeah, but like in terms of, well, is the early trigger reverse trigger? Is it because my ventilator is too fast? Because I've seen that in a, let's say, in a patient who is supposed, let's say, 2 weeks out of ARDS, I put in the ventilator too fast, or is it because the patient is too sedated? So just to give an example of early trigger, that is, I mean, of course it's to the goals, but I guess what I'm trying to say is that the discordance is, I feel that, okay, is it P vent too much or P must too much? That's where the ultimate discordance comes, right? I mean, you can discuss on what phase, and that's the taxonomy.
So you're talking about the etiology.
Yes, I think and then go to the taxonomy, I guess.
Well, I would have to say that that would be like putting the cart before. So if you say the etiology and then describe the the taxonomy based on that, then you would have to quantify the amount of effort for each patient, and then from there you would have different classifications.
Fair. Okay.
So I think that, I mean, this is a challenge with any classification that comes out, that you have to come to terms and sit down and say, well, what's the most operationally efficient one? And then it's going to mutate through time. There's no question about that. I don't know, Rob.
Yeah, it's difficult to separate those things out, but I agree pretty much with what you're saying. And I'll bet you though, just as a side thought, that physiologically there's something like an inspiratory trigger reflex and an expiratory trigger reflex, like we saw before. I think the lungs are somehow reacting to rapid changes in volume, or the brain is. I don't know. Just a speculation.
Any other comments? Is there comments on the chat, Rob?
Nope.
Very good. Alrighty. So really good pondering on how on this process of trying to do the taxonomy, how to put this under context, and what are the potential causes for it. Now, this patient has a respiratory rate already of 15. What would you do for this patient, Udi? Would you drop the rate? Would you just drop the sedation? What's your goal here? I mean, he's on 8 PEEP and 80%, so I assume that this comfort, it's safety, what we're handling here. What would you do?
I would reduce sedation, and I'm surprised with that 80% because the patient seems to have a fantastic compliance. I mean, P mean is 11, P, it seems like.
Well, be careful with the tidal volume, right? Because it's a tidal volume that will deliver, and there's PMOS there. So whenever there's PMOS, your compliance is gonna look fantastic.
Okay.
Right?
Yeah. But yeah, I would still reduce sedation, I think.
Alrighty. So question mark sedation. Any other intervention or any other difference? Any other from anybody else?
Just to test the theory, I might still as well just drop it a little bit and see what the patient does. I'm not saying that I'm going to necessarily drop it and leave it there. And then one thing that would help is obviously knowing the patient gases. Can I tolerate how low of a minute ventilation can I tolerate? Funny enough, yesterday in the unit, we had a patient actually who had reverse triggering, very similar. The rate was at 15 and she was breathing at 14. Once I dropped the rate to 12, she was breathing on her own at 14, same minute ventilation, but you gotta be aware that if she drops, she's gonna drop back to 12. Are you happy with that minute ventilation or not? So we left her at that, and she didn't do any more reverse triggering whatsoever. I find it funny that it was 15.
Absolutely. So the other thing that I would put here is don't forget your end expiratory occlusion maneuver. That can also give information regarding what's the drive or not of the patient, right?
Yeah, plus this is a servo. You could just use IMV type 2, right? Just put auto mode on.
Right. That's another
problem will go away automatically.
Very good. So we had excellent 3 cases discussed today. Very juicy discussion. Here's the CME for those that want a CME and want to scan that. There's other 3 that we could do later on in one more, because they donated really good cases here from Hospital Ángeles of Interlomas. And Oscar, right? Alvaro. And what's your last name, Alvaro? Martin. And now we have also Alvaro Martinez, another one of the second year residents or fellows actually down here. So here's send us your waveforms. Here's the CME QR code for the CCF caregivers. And then if you want to go to the SEVA webpage, with that, I will say a goodbye with the whole team from Hospital Ángeles, and thank you very much for joining us.